Dr. Barry Cosgrove was the surgical intern on St. Joseph's Ward, responsible for medical note-keeping and daily tasks, under the direction of the registrars and the consultant. Here we see an entry in the clinical notes by senior surgical intern on call Dr. Shine at 1:30 a.m. on October 12, referring to her been called to review a seizure at 11:55 p.m., on the night of October 11. Dr. Shine has documented, seizure lasted 1 minute. Dr. Shine was questioning tonic-clonic seizure with arms and legs flailing, clenching teeth but no urinary incontinence. Bernard Bingham, Mirek's dad, was with Mirek in his room from 4 p.m. on October 11, and during that time he requested Dr. Barry Cosgrove to get help for Mirek, as he was having tonic-clonic seizures. Dr. Barry Cosgrove advised Mirek's dad that the neurology team were aware of Mirek's condition. Dr. Cosgrove then went off duty at around 6 o'clock that evening. On several occasions Mirek's dad requested the nursing staff to get help for Mirek, but with no results. At 9 p.m. seizures become more violent and Mirek's dad once again tried to get help from the nursing staff by ringing the emergency bell on Mirek's bed, but no help was forthcoming. It is important for the viewer to know, from the day of his surgery October 4, 1999, Mirek was in a ward by himself on the surgical floor in the hospital. So Mirek's dad, when left with no option, left Mirek alone in the room and went down the corridor to try and get help for Mirek, where he found the nursing staff in a room discussing the nursing strike. He requested someone to come and help Mirek, and was told somebody would come shortly. After approximately 15 minutes no help had been forthcoming from the nursing staff. On arriving back to Mirek's ward, Mirek's dad left the door open to see if any of the medical staff were passing by, so he could call for help. Sometime after this Mirek's dad called the first passerby he had seen to get help for Mirek. That person happened to be Nursing Officer Mary Wallace, who immediately on seeing Mirek's seizures commented, "My God, this boy needs help." Nursing Officer Mary Wallace has made no documented report of Mirek's condition or the treatment he received during her attendance on Mirek. As we have seen from the clinical notes, there are no reports of Mirek's condition or treatment during this period, until the note by Dr. Shine at 11:50 p.m. documenting what Dr. Shine had witnessed at that time. Here we see the next note documented at 12:30 p.m. And as can be seen, the note is documented by a senior medical house officer on call, who was called to review seizure. The senior house officer has documented background noted, and that the patient was unresponsive. Nothing is documented by the senior house officer regarding a diagnosis of Mirek's condition. The senior house officer has not documented any treatment for Mirek's condition, does not comment on any neurological examination to explain Mirek's responsiveness. It must also be pointed out, this senior house officer has not signed this review. Medical Registrar on call Dr. Kelleher has documented, this PM Myoclonic up. Tonic-clonic seizures by 3 witnessed by intern, senior house officer, nursing staff, variably. Parents stated that myoclonus similar by days. Dr. Kelleher also documents, on arrival, persistent myoclonus, short burst slashing, 5 to 10 seconds of seizure. Also some periods of rest. Here we see Dr. Kelleher has documented Mirek's Glasgow Coma score as Eyes 1, Verbal 1, Motor 1, which is equal to a Glasgow Coma score of 3/15, meaning Mirek was unconscious. Dr. Kelleher has also documented issues, question status epilepticus versus refractory myoclonus, plus, coma in brackets due to benzodiazepines. Dr. Kelleher has also added what would appear to be an addition to the clinical notes, which were the benzodiazepines used to treat Mirek's condition. Neither Dr. Kelleher nor the clinical notes indicate at what time Mirek received the IV benzodiazepine treatment. It is more likely the coma was caused by status epilepticus and not the benzodiazepine treatment. Here we see a continuation of Dr. Kelleher's notes. Dr. Kelleher has documented for phenytoin 650 mg over 30 minutes intravenously. Mirek's weight is not specified. Dr. Kelleher is also recommended disconnecting erythromycin, as in his opinion, erythromycin can precipitate seizures. This note also indicates Mirek had been seen by the anesthetist Registrar, suggesting Mirek be transferred to the high dependency unit. In the next note at 2:20 a.m. on October 12, Dr. Kelleher documents, bed ready. No porter available and Dr. Kelleher himself willing to act as porter. But it appears from Dr. Kelleher's note, HDU were not ready to accept Mirek until 2:50 a.m. as the nursing staff were not available, so a request was made for phenytoin intravenously to be given on the ward. The following page is from notes by Dr. Duffany, for high dependency unit admission, timed between 3:30 a.m. and 4:30 p.m. This note also documents seizures this evening. Uncontrolled with benzodiazepines. Glasgow coma score 3/15. Easy oxygenation. The note also documents on phenytoin started now, indicating the phenytoin was not started until sometime between 3:30 a.m. and 4:30 a.m. Therefore Mirek was left in status epilepticus for several hours, without the protocol for the treatment for status epilepticus been adhered to. This is the second note by Dr. Duffany. This note was documented at 5:30 a.m. on October 12, and documents admission to the intensive care unit. The first note referred to admission to HDU. Dr. Duffany documents seizures uncontrolled with phenytoin. Responded well to 75 mg of thiopentoin. In his evidence to the inquest, Dr. Brian Marsh, intensive care director, stated the following. I haven't got the notes up here with me, but I think you will find that there is a page of intensive care notes on the 12th signed by one of our registrars which describe the administration of 75 mg of thiopenton to settle the seizure activity at the time. Coroner Dr. Brian Farrell then asked, "Can you help us at all with the you can't make any comment on the 12th? Dr. Marsh, I can comment on what I have read in the notes. Coroner, oh I see. So you did say you were not on call that night? Dr. Marsh, I wasn't on call that particular evening in my read of the notes, if that's helpful. What it says, that it was a transient admission, that the events giving rise to it, seemed to settle satisfactory, and the review by Dr. Lynch and by ourselves in the daylight hours suggests that it was a safe and reasonable process to move the patient forward, back to the ward area. Comment: when referring to Dr. Dauphine's treatment and successful termination of status epilepticus during the inquest, Coroner Dr. Brian Farrell stated the following: "Now the formal diagnosis, and I know that the diagnosis of epilepsy was offered by the registrar on the 11th, but it's the consultant who makes the formal diagnosis." Strange events. This is a very strange comment, from a consultant neurologist. Dr. Lynch then goes on to document last night, the series GTC lasting 30 seconds to 1 minute. Generalized tonic-clonic seizure is one type of seizure that involves the entire body. It is also called grand mal seizure. The terms seizure, convulsion, or epilepsy are most often associated with generalized tonic-clonic seizures. Lethargy is a symptom that causes you to feel sleepy or fatigued and sluggish. This sluggishness may be in terms of movements or in thinking. You're described as lethargic if you have these symptoms. www.healthline.com web link. Lethargy was not documented in the clinical notes by any of the healthcare professionals treating Mirek between 11:55 p.m. and 5:30 a.m. on October 11th and 12th. The clinical notes indicate Mirek's Glasgow Coma score as 3/15. Glasgow Coma score is a recording of the conscious state of a person. Therefore, during this period Mirek was unconscious. Furthermore, Dr. Lynch was not present between 11:55 p.m. on October 11th and 5:30 a.m. on October 12th. Lethargy was a total misinterpretation by Dr. Tim Lynch of Mirek's conscious state during that time. This page from the clinical notes documents Dr. Tim Lynch's impression of the events the previous night, early morning. He states, "Unclear cause for GTC and myoclonus. He did not have an epidural for analgesia, so an epidural collection is unlikely. The myoclonus and GTC could be psychogenic, but we should exclude an infection first." Comment: Dr. Tim Lynch's impression was, unclear cause of generalized tonic-clonic seizures in myoclonus. Yet, there were a number of possible causes, but none of these were considered. The only diagnosis considered as the cause of generalized tonic-clonic seizures in myoclonus by Dr. Tim Lynch was a psychogenic cause. Dr. Lynch, on reviewing Mirek for the second time on October 12, 1999, documented his final impression of Mirek's seizures as psychogenic seizures myoclonus, without first considering an EEG to confirm his final impression. On October 14, Dr. Lynch once again confirms his final impression of psychogenic seizures myoclonus when he documented in the clinical notes, "Problem is stress-related," and requested a psychiatry consultation. Dr. Lynch also suggested phenytoin, the anti-seizure medication, to be weaned off over 2 days, further confirming Dr. Lynch was quite clear the seizures were psychogenic and not epileptic seizures. Dr. Tim Lynch stated, "He did not have an epidural for analgesia, so an epidural collection is unlikely." Dr. Tim Lynch was incorrect. Mirek did have an epidural for analgesia between October 4 and October 7. The doctor on call removed the epidural on October 7, as he considered it to be a possible cause of the myoclonus twitching. Therefore, it is unclear why Dr. Tim Lynch on October 7 1999 ignored this entry by the doctor on call, and dismissed an epidural collection as a likely cause of the myoclonus. Secondly, Dr. Tim Lynch failed to consider the possibility that the seizures were triggered by the operation. Thirdly, Dr. Tim Lynch failed to consider the presumed hypoxia around the time of the pneumothorax as a possible cause of the myoclonus. Fourthly, Dr. Tim Lynch failed to consider another likely cause of the myoclonus could have been that the seizures were caused by pain from the chest drain tube inserted in Mirek's side on October 4, 1999, the day of his surgery, and remained there until October 19, 1999, when the pneumothorax finally resolved, after management of the chest drain was taken over from Professor Tom Gorey's surgical team by the cardiothoracic team on October 14, 1999. So, up until October 11, 1999, this amounted to a total of 7 days in which Mirek had a chest drain inserted in his side. The chest drain caused Mirek excruciating pain as it was tied to the headrail of his bed and was being pulled by the myoclonic shaking. The normal duration for a chest drain to resolve a pneumothorax is considered to be 2 to 3 days. After October 7, 1999, the chest drain remained in Mirek's side for a further 12 days, until it was removed on October 19, 1999. Fifthly, it should be noted here, that the first swabs for MRSA were not taken from the chest drain site until October 16, 1999. The swabs were not delivered to the on-site hospital lab for analysis until October 18, 1999. The MRSA test results were positive for MRSA, and were available on the hospital computer on October 20, 1999, but were not reviewed until October 21, 1999, and no treatment was commenced for the MRSA until following a review by Dr. James O'Riordan at 4:40 p.m. on October 21, 1999. Sixthly, Dr. Tim Lynch did consider the possibility that the myoclonus could be organic, but states he had no clear cause for epileptic seizures. Dr. Tim Lynch failed to consider the fact that he had prescribed only low levels of Rivotril, clonazepam, for Mirek's seizures, and which Mirek was only receiving intermittently. Dr. Tim Lynch did not consider this to be a cause of the continuing myoclonus, twitching, but persisted with his diagnosis that they were most likely to be psychogenic or non-epileptic seizures. Seventhly, Rivotril was not given to full therapeutic levels. Mirek was on a total of 1.5 mg of Rivotril per day. Full therapeutic levels of Rivotril are approximately 8 mg a day. The Bingham family's expert witness neurologist Professor Fenella Kirkham in her report stated, had he had an EEG when the seizures started, on October 7 or 8, 1999, and had the seizures been managed consistently according to a Status Epilepticus protocol, it would have been much easier to have controlled these seizures whatever the underlying etiology. Mirek might well have not required ventilation and intensive care unit management, or if he had, this would have been required for a much shorter period. On the October 12, 1999 Mirek was admitted to intensive care during the night because of the frequency of the twitching episodes, and he was considered to be in possible status epilepticus the following day. However, although he had a lumbar puncture to exclude infection and a CT scan, did not have an EEG at this stage. Dr. Lynch still considered that these were most likely to be non-epileptic seizures, although he suggested using phenytoin and clonazepam to control the seizures/myoclonus. It is clear that he was mistakenly diagnosed as having pseudoseizures, when in fact he was in status epilepticus with myoclonic manifestations, which was not diagnosed until he had an EEG on the October 21, 1999. Here we see Dr. Tim Lynch suggesting, 1. Prolactin level if low then likely to be pseudoseizures. Note: prolactin level rises predictably only after a single seizure. Patients who have more than 2 seizures in 12 hours have progressively smaller elevations, presumably because stored prolactin from the pituitary lactotrophs is exhausted. 10% to 20% of patients with tonic-clonic seizures may not show a post-ictal prolactin rise. Complex partial seizures that do not arise from the temporal lobe do not lead to prolactin elevation. Post-ictal serum prolactin elevation cannot be used to differentiate simple partial seizures or absence seizures from non-epileptic seizures. On this page from the clinical notes, Dr. Tim Lynch documents, discussion with parents. They believe his twitching and GTC are anxiety-related. He was told at 5 p.m. yesterday that the chest tubby would be in for a further 2 days. He has had previous twitching episodes. Suggest 1. Minimal intervention. Here we see the final entry in the clinical notes by Dr. Lynch for October 12, 1999, where he has documented, final impression. Psychogenic seizures, myoclonus. In his statement to the Irish Medical Council, Dr. Tim Lynch states, Mr. and Mrs. Bingham have completely misunderstood the reference to minimal intervention. Dr. Tim Lynch also states, at no stage did they ever seek clarification. It would appear that it is Dr. Tim Lynch who misunderstands the meaning of minimal intervention. Minimal intervention in a hospital situation means, least possible intervention. Definition of minimal, the least possible. Dr. Tim Lynch further stated, Mirek's parents requested specifically that painful procedures be kept to a minimum, and therefore I documented in the notes, minimal intervention, meaning that painful procedures and tests should be kept to a minimum as per Mirek's parents' request. However, at the same time I requested a lumbar puncture, CT brain scan, a consult to Mr. Michael Stevens, consultant orthopedic surgeon, and all other medical and surgical treatments necessary for his ongoing management of his pneumothorax post-Heller's myotomy. This statement by Dr. Tim Lynch is simply untrue. Nowhere in the medical records does Dr. Tim Lynch document what he meant by minimal intervention. Therefore, it is exactly what it means, minimal intervention. Nowhere does Dr. Tim Lynch document that Mirek's parents requested painful procedures and tests should be kept to a minimum. Parents seeking treatment of their son's epileptic seizures would not refuse procedures and tests that would assist in diagnosis and treatment. Dr. Tim Lynch, under the Irish Constitution and in line with medical guidelines, was not permitted to give an instruction of minimal intervention in the absence of written consent by Mirek's parents. Dr. Tim Lynch's minimal intervention suggestion was to deter the healthcare professionals from treating Mirek for epileptic seizures as they had on the previous evening, and that morning. But, as can be seen from reading the medical records, after Dr. Tim Lynch's minimal intervention suggestion, the healthcare professionals were applying the minimal intervention suggestion to all procedures concerning Mirek's treatment. It would appear no clear documented assessment was made by Dr. Tim Lynch to show that minimal intervention was in Mirek's best interest. Dr. Tim Lynch's minimal intervention suggestion was causative, and created an environment in which nurses, doctors and medical staff then treated seizures, anti-epileptic medication, pain management, desaturation, poor expectoration, decreased responsiveness, respiratory distress, neurological observation, MRSA, infection, sepsis, respiratory acidosis, a pH of 6.99, high temperature, fluid intake, chest tube management, declining nutritional status, increased general weakness etc. in a far less interventional way than would have been the case had Dr. Tim Lynch not suggested minimal intervention. Dr. Tim Lynch states that he requested all other medical and surgical treatments necessary for his ongoing management of his pneumothorax. No such request is documented in the clinical notes or medical records. On October 14, 1999, 10 days after insertion of the chest drain, Mirek's parents became concerned with regard to the pain and suffering the chest drain was causing Mirek, and at the length of time the chest drain had been inserted in Mirek's chest cavity, and the pneumothorax had not been resolved, due to mismanagement by the surgical team. The normal recommended time for chest drain insertion for treatment of a pneumothorax is 3 to 5 days. Mirek had a chest drain inserted in his left chest cavity for 15 days in total. Note: pneumothorax treatment includes insertion of a chest tube in the chest cavity. This allows the air or fluid to escape from the pleural space, and prevents anything returning to the chest. The chest tube is a flexible plastic tube that is inserted through the chest wall and into the pleural space or mediastinum. On October 14, 1999, Mirek's mum had to make several requests to matron Marie McElhinney for the cardiothoracic team to take over care of the chest drain and pneumothorax without success. It was only after Mirek's mum informed matron Marie McElhinney that she was left with no alternative but to report the mismanagement of the pneumothorax to the hospital administrator. Matron Marie McElhinney agreed to Mirek's mum's request for the cardiothoracic team to take over care of the chest drain and pneumothorax. Within 4 days of the chest drain management by the cardiothoracic team, the pneumothorax was resolved. Therefore, it is implausible that Dr. Tim Lynch is claiming that the surgical team were following his request for ongoing management of Mirek's pneumothorax, in particular when there is no written record of this in the clinical notes by either him or anyone on the neurology team. Dr. Tim Lynch further stated, "It is clear that Mirek had ongoing daily care from the combined services of the surgical team, neurology team, cardiothoracic services, and intensive care services." Mirek's parents state that the medical records do not support this statement by Dr. Tim Lynch. Day-to-day morning round reviews are not documented by the surgical team, Professor Tom Gorey, Dr. Barry Cosgrove, Dr. James O'Riordan, or Dr. Bridget Egan. The surgical team have not documented witnessing Mirek's seizures, when on 4 occasions, when they did do ward rounds, and they witnessed Mirek was seizing. Dr. Barry Cosgrove, who in his sworn evidence to the coroner's inquest, claimed he was responsible for the day-to-day note-taking for the surgical team. Dr. Barry Cosgrove has not documented a detailed clinical description of the myoclonus or the seizures he witnessed on the 11th, 19th, 20th and 21st of October 1999. The neurology team did not review Mirek on a daily basis. Between October 4, 1999 and October 21, 1999, the neurological team reviewed Mirek on the 8th, 12th, 14th, and 19th of October 1999. That is a total of 4 reviews over 18 days. On October 14, 1999, Dr. Tim Lynch did not review Mirek until he was requested to do so by Dr. Barry Cosgrove. On October 19, 1999, Dr. Tim Lynch did not review Mirek, until at Mirek's parents' request, Dr. Cosgrove once again requested Dr. Tim Lynch to review Mirek's seizures. Between October 8, 1999 and October 21, 1999, the neurological team failed on 6 occasions to attend to Mirek when requested. October 8, 1999 Nursing AM report, Patient continues to twitch A/W neurology. Dr. Tim Lynch's neurological team did not attend to Mirek until 5:30 p.m. Mirek at this time had been twitching for approximately 10 hours. October 11, 1999 Nursing PM Report, S/B Neurology Team, Allen 200 mg. Allen is not used for seizure treatment. Dr. Tim Lynch failed to come and assess Mirek. October 12, 1999 Clinical Notes, spoke to Dr. J. Wiley, Neurology Team. Dr. Joe Wiley took no action. October 20, 1999 Dr. Tim Lynch's neurology team failed to attend to Mirek when requested by patient services. Mirek's parents were so concerned for Mirek's life, that Mirek's mum reported Mirek's condition to Julie Lacey in patient services requesting urgent intervention. Through a FOI request, Julie Lacey has confirmed the meeting took place with Mirek's mum. Mirek's mum left patient services after being assured that the healthcare professionals were contacted, and that Mirek would be seen by them. On her way back to Mirek's single observation room on St. Joseph's Ward, Mirek's mum met Dr. Joe Wiley, the neurology registrar. Mirek's mum asked Dr. Joe Wiley to help Mirek, explaining she was afraid that Mirek would die if the seizures were not treated. Dr. Joe Wiley's answer was, "He is not my patient," and he continued on his way. On Mirek's mum's return to his bedside, Mirek's dad confirmed that the request by patient services for treatment of Mirek's seizures was not acted upon by the healthcare professionals on St. Joseph's Ward, or the neurology team, as no one had attended to Mirek. October 21, 1999 Nurse Colette Burke documented 15 seizures, team aware. Neither the surgical team, nor the neurology responded to, or took any action to the continual seizures throughout the day, 15 of which were recorded by Nurse Colette Burke. Mirek did not recover consciousness following these seizures, and Nurse Colette Burke noted that he was drowsy and unable to take his medication. On several occasions throughout the day, Mirek's mum asked Matron Marie McElhenney and Nurse Colette Burke if the seizures would harm Mirek. Nurse Colette Burke did not respond and looked to Matron Marie McElhenney, who verbally assured Mirek's mum that the seizures would do him no harm. October 21, 1999 Dr. James O'Riordan documents at 4:30 p.m. in the clinical notes, spoke to neurology team. Dr. Joe Wiley, neurology team, later inserted an addition to this clinical note, stating not informed of high WCC, white cell count. Told he had a fit. Dr. Joe Wiley in this note is confirming that he was obeying Dr. Tim Lynch's suggestion of minimal intervention, by refusing to attend Mirek to treat his epileptic seizures. This was despite Dr. James O'Riordan's same entry at 4:30 p.m. in the clinical notes. Pseudoseizures, one apnoic episode. Dr. James O'Riordan further notes at point 5 of his plan, Dr. Lynch to speak to family in the morning. Mirek was critically ill, yet Dr. Tim Lynch was not going to review Mirek's condition until the morning. It is quite clear from the entries on October 21, 1999, that there was a conflict of opinion between the nursing, surgical and neurology team regards Mirek's condition, as they were now questioning Dr. Tim Lynch's final impression of pseudoseizures, yet it appears that they failed to act and treat the seizures because of Dr. Tim Lynch's suggestion of minimal intervention. Further evidence of minimal intervention was on October 16, 1999, when the physiotherapist documents, increased generalized weakness ++ over past week, especially trunk and RUL falling ++ to right side and unable to self-correct or maintain unsupported sitting. The medical records show no action was taken to address Mirek's deteriorating condition by the physiotherapy team. On October 19, 1999 the chest drain with MRSA was removed without any pain medication, blood-stained cotton swabs were left on the bed and floor. The Mater Hospital is unable to identify the Muslim doctor who without assistance removed the chest drain, and who left the room while Mirek was having a generalized tonic-clonic seizure, which was witnessed by Mirek's sister Daria and a family friend Geraldine Minto, who sought assistance from Dr. Barry Cosgrove. Dr. Barry Cosgrove has not documented requesting assistance from the neurology team to treat the epileptic seizure. October 20, 1999, Dr. James O'Riordan, now a consultant, discontinued the antibiotics without checking Mirek's temperature, or that the infection had cleared. Blood had not been taken since October 15, 1999. Bloods taken on October 21, 1999 confirmed that Mirek had sepsis. So, it is highly likely that because of the delay in diagnosis, Mirek had untreated sepsis since October 15, 1999, 7 days prior to confirmation by the blood test on October 21, 1999. The intensive care services were involved in Mirek's care on October 12, 1999 for approximately 6 hours, and from October 21, 1999 at 9 p.m. until December 31, 1999, the day Mirek passed away. During the inquest, Dr. Barry Cosgrove and Dr. James O'Riordan from the surgical team, when asked to comment on Mirek's myoclonus, twitching, turns, panic attacks, seizure-like episodes, stated they were following Dr. Tim Lynch's suggestion of minimal intervention. A similar scenario can be seen in the conduct of the healthcare professionals treating Mirek from October 12, 1999, until 7 p.m. on October 21, 1999, where Mirek did not receive intervention from the surgical team and nursing staff, despite their awareness of Mirek's worsening condition, until at 7 p.m. on October 21, 1999, Dr. Tim Lynch instructed Dr. Rachel Cooney to treat Mirek for seizures, following verbal confirmation of epileptic seizures from the EEG technician. Therefore, between October 12, 1999 and 7 p.m. on October 21, 1999, Dr. Tim Lynch's minimal intervention suggestion was interpreted by the healthcare professionals as not to treat Mirek for seizures, following the intervention by Dr. Kelleher and Dr. Duffany on the early morning of October 12, 1999. The Bingham family reject Dr. Tim Lynch's explanation of his minimal intervention suggestion as incredulous and absolute nonsense. It is clear from this evidence, taken from the medical records, and from the Bingham family's eyewitness evidence, that Dr. Tim Lynch's statement to the Irish Medical Council is misleading and factually incorrect, as Mirek was not having the most basic daily health care from the combined services of the surgical team, neurology team, physiotherapy services, cardiothoracic services, and intensive care services. Here we see Dr. Dufany as documented anesthesia ICU admission at 9 p.m. Dr. Dufany also documents an arrest call at approximately 7 p.m. 16-year-old, who was spontaneously hyperventilating, and was apnoic and blue for 2 minutes before he arrived. This note also documents a Glasgow coma score of 3/15, indicating Mirek was unconscious. This is a continuation of Dr. Dufany's previous note. In this note, Dr. Dufany documents seized twice today and once in CT. This is incorrect. Nurse Colette Burke has documented in the nursing notes had approximately 15 episodes of seizure-like activity today. At 4:30 p.m., Dr. James O'Riordan has documented fitting at the time, and the EEG report documents Mirek having 3 epileptic seizures while undergoing an EEG at 7 p.m. This is a total of at least 20 documented seizures on October 21, 1999. This note by Dr. Dufany also documents diazepam 10 plus 10 mg in CT. Diazepam is a benzodiazepine. Diazepam affects chemicals in the brain that may become unbalanced. Diazepam is used to treat seizures. IPPV, positive pressure ventilation, means that airway pressure is applied at the patient's airway through an endotracheal or tracheostomy tube. Here we see Dr. Dufany has documented a plan for IPPV, positive pressure ventilation, and phenytoin. The exact time this plan was actioned is not clear, but it would appear from Dr. Dufany's note seen here, which was documented at 9 p.m., the plan for positive pressure ventilation and phenytoin was sometime between when Dr. Dufany documented a plan for IPPV and phenytoin and at 10:30 p.m. when Dr. Rachel Cooney reviewed Mirek in intensive care, and documented, intubated, ventilated, and intravenous phenytoin loading dose given. Coroner Brian Farrell made the following statement during the inquest: even when the diagnosis was made, and Mirek was in the intensive care unit, having anticonvulsant treatment, the seizures were very difficult to control. Comment: anticonvulsant treatment in the intensive care unit was ineffective in controlling the seizures because the delay in requesting the EEG resulted in a diagnosis of non-epileptic seizures, when in fact Mirek was in status epilepticus with myoclonic manifestations for 14 days. The reduction of phenytoin on October 14 from 300 mg to 150 mg and then the stopping of phenytoin on October 18, and the inconsistency, unavailability, and low dose of Rivotril, resulted in Mirek being allowed to enter into a situation where status epilepticus on October 19, 20th, 21st, resulted in uncontrollable status epilepticus. On October 21, 1999, Mirek had approximately 20 epileptic seizures documented in the medical records, without recovery of consciousness, or in other words Mirek was in status epilepticus. At 7 p.m. on October 21 Mirek had 3 recorded epileptic seizures while having an EEG, and without intervention Mirek suffered a respiratory arrest during one of those seizures, from which he never recovered consciousness. Mirek's seizures were very difficult to control because of Dr. Tim Lynch's failure to use thiopentin on October 21, 1999 to control status epilepticus. As we have already seen in this video, Mirek was not treated with thiopentin until midnight on October 22, 1999, and that was only on the instructions of Dr. Brian Marsh, director of the intensive care unit. Dr. Tim Lynch did not suggest the use of thiopentin to control the intractable status epilepticus. But at that stage the treatment with thiopentin was not effective, as once again Dr. Tim Lynch delayed in following the protocol for the treatment of status epilepticus. Dr. Tim Lynch was aware that on October 12, 1999 seizures did not respond to phenytoin. Knowing this, at approximately 7:50 p.m. on October 21, 1999, having been informed by Dr. Rachel Cooney that the EEG confirmed Mirek did have seizures, Dr. Lynch instructed Dr. Rachel Cooney to treat Mirek's events as seizures, and commence phenytoin. Thiopentin was the most suitable drug for the management of Mirek's status epilepticus, as was proven on the morning of October 12, 1999, when Mirek's seizure activity was not controlled with phenytoin, whereas when 75 mg of thiopentin was used Mirek's seizure activity settled. This fact is confirmed in Dr. Brian Marsh's evidence to the inquest when he stated, "I haven't got the notes up here with me, but I think you will find that there is a page of intensive care notes on the 12th signed by one of our registrars, which describes the administration of 75 mg of thiopentin to settle the seizure activity."